let's turn to our monthly meeting presentation. It makes sense to just go right into that, and we'll do all kinds of updates after. But Stacie, I hope we did not steal your thunder by just jumping into one of the specific issues, but it made sense and to me to start asking questions. We are so
Ab- Absolutely. No, I love it. It's very organic. So that's
yeah.
perfect.
And speaking of organic, a few of us, I think Sangeeta and I watched you present with Morissette and the South Carolina coalitions back in January when you did the overview of the new CAPC serious illness care report card. You did a South Carolina highlighting focus, and we were like, oh, we got to have her come to North Carolina. And before the meeting even ended, I emailed you. You were great. So really excited for you to do a similar presentation, but now focusing on North Carolina and how we can do, you can offer the state look at palliative care capacity. I'll just say Stacie Sinclair is the Associate Director of Policy and Care Transformation with the Center to Advance Palliative Care, lovingly known as CAPC. And with that, I'll stop talking and tell us more about how we did on the scorecard.
Yes, thank you so much for having me today. I'm really excited to be with you and share. Heather, this presentation will look very similar, but like I said, or like you said, specified to North Carolina. So I will go ahead and share my screen. All right, so yes, that's me. We're talking about the scorecard today and how North Carolina performed. And before I dive in, I do want to just say that the Center to Advance Palliative Care has reinstated its national seminar. So this is the first time since the pandemic that we will be meeting again in person. And so we would love to have um, anyone who is interested in coming out to Philadelphia to come join us. So can everybody see? I just want to make sure that the slides are working.
Yes, there are these like funky black spots that are
And,
do other people see that too on the present? Oh, it just went away. Okay, it just had
okay,
to do what they think where your cursor was.
perfect. Oh, okay. All right. Well, thank you. All right. So now diving into the content. So why a serious illness scorecard? Um, so this won't come as a surprise to anybody on the call, but we know that there are millions upon millions of people living with serious illness in the United States today. This is probably an undercount, and that number is expected to grow. And we know that serious illness affects folks across the lifespan. So not only are we looking at adults and older adults, but also children living with serious illness and their families. And we know that the healthcare system is not well matched to the needs of patients and families. So, patients, when they are diagnosed with serious illness, they often have misunderstandings about what to expect, unclear information on their prognosis, and their treatment decisions aren't informed, or treatment decisions from the care team are not necessarily informed by their values and preferences. Pain and symptoms are poorly managed, and so tend to be a huge driver of visiting the emergency department because there isn't that proactive management, but some of these could be avoided. And then approximately 1/5 of families or others would consider themselves caregivers. And so really what they need is what patients and families need is a better system to support quality of life during serious illness. They need regular screening for their symptoms. They need to be able to talk with their clinicians about, first of all, who are they? What does quality of life mean to them? And then how is it that they can match the treatment plan to what is quality of life? Obviously, supporting our family caregivers who are the backbone of the US healthcare system and get so little support and resources for the invaluable work that they do. And this should really be the responsibility of every clinician working in the healthcare system, but then for particularly complex cases, then the availability of specialty palliative care. I also do want to highlight that CAPC has done some work in recent years, and Marisette has been a tremendous part of that, to better understand also disparities and inequities in care experiences for diverse populations living with serious illness. And so we have done recently 2 projects, one looking at the experiences of Black patients living with serious illness, and then the other for Hispanic and Latino patients living with serious illness. And both of these projects have first involved a literature review to understand what are those care experiences, what are some of the issues that are reported, and then on the second side, what are some of the interventions that have been demonstrated to be effective? And so actually the findings from those literature reviews are available for free on CAPC's website. I can drop those links in afterwards. But this just demonstrates that we know that care isn't inequitable. And so of older adults who have reported that they haven't had their care preferences considered, we see significantly higher percentages of Black and Hispanic patients who don't feel like their preferences were taken into account. And then also much higher ED utilization in the last month of life among Black and Hispanic patients, much higher than white patients. And so there's a real need and opportunity to address those inequities in care. So bringing in the new scorecard, some of you may be familiar with the previous state-by-state report card. And this was a product from both the Center to Advance Palliative Care and the National Palliative Care Research Center. The first edition was released in 2006, and this is really as the field of palliative care was getting started and gaining some momentum, that we needed a way to communicate out what is palliative care, what do we know about the foundation of where it exists, and then also have some recommendations to advance the field. Because there wasn't a lot of data, where we started was with what we had, which is the number of hospitals with 50 or more beds reporting a palliative care program. We got this information from the American Hospital Association survey. And so what we did was basically look at that survey, identify the programs that had reported a palliative care program, calculate that into a percentage, and then assigned letter grades based on that percentage. And that was what we considered for each of the 4 different editions of the report card. And I think it's fair to say that this was actually a really successful endeavor, because what we saw was over these 4 editions, the grades really increased over time, and we were able to get better information about palliative care, a lot more recognition among policymakers about what it is, and really just, again, like that, build that foundation. That said, as we started to consider would we do another edition of the state-by-state report card, what we had seen, particularly in the 2019 edition, is that these grades had started to level off, that states were pretty much staying the same. We had a pretty high percentage of A and B states, and that because of changes in the US healthcare system, that either they're staying the same, or in some cases, the grades were starting to go down. And the field of palliative care has grown significantly. There's more evidence, there's more data. Palliative care is being delivered outside of the 4 walls of the hospital. And so we decided that it was time to look at a new way to tell the story of palliative care capacity. So enter the serious illness scorecard. We published this new edition at the end of 2024. And so really this looks beyond just the metric of hospitals reporting palliative care to incorporate other metrics that we think support each state's ability to either advance palliative care initiatives or offer palliative care to people who need it. So as I mentioned, the first report card was really only based on this one measure, which is the proportion of states' hospitals with 50 or more beds self-reporting a palliative care program or unit. So we have now expanded that metric to 10 variables across 5 domains of care. So we did carry over this metric, but then we also brought in the count of states certified hospice and palliative care professionals per 100,000 in the population. We've also seen an increase in payment activity. So now, what are states doing to pay for interdisciplinary palliative care, their policies that exist? Commercial health plans, are they doing anything to support palliative care and bringing that in? We know that the growth of palliative care across the country would not happen without concerted advocacy and the efforts of champions like your organization. And so wanted to be able to give credit for where this activity was happening in each of the states. We also know that there's never going to be enough specialty palliative care to meet the needs of everyone living with serious illness. And so that's why we wanted to look beyond specialty palliative care to see if there was any capacity building across all clinicians. So whether or not there were relevant medical or nursing continuing education requirements. And then because this is the data that we at CAPC had access to, the count of clinicians who completed at least one CAPC course per 10,000 clinicians in the state. And then finally, knowing that the experience of people living with serious illness also goes beyond palliative care in general, we looked at 2 other measures. So one was the existence of a Medicaid waiver for children with serious illness that goes beyond the standard services that we see in every state. And then we also looked at the AARP long-term services and supports scorecard to see how well each state fared in community-based and long-term services. So with that, that's the sort of the overview of how we restructured the methodology. So how did North Carolina do? The score is 2.5 stars. And I will go ahead and let you know that all of the images that you're going to see on the subsequent slides are available on CAPC's scorecard website. And so I think what's important to note here is that the difference now is that we want to reflect that every state is doing something. So this is a heat map. So obviously the darker the color, the higher the grade. But again, part of the reason that we wanted to revisit the methodology is because availability of hospital palliative care really only tells one bit of the story. And that we knew that there were states that were also doing really important work that we wanted to make sure that we were able to highlight and then also give information about where they could take action next. So drilling a little further into North Carolina's grade, this is a cheat sheet of how points were assigned. And so within each domain, we gave a color to whether or not the variables within the domain scored above the median or didn't score above the median. So in specialty palliative care, structured champions, advocacy and support, and foundation for functional and caregiver support, you had one variable within the domain that scored above the median. And then for payment and special building skills outside specialty palliative care, there were no variables that were given credit for that particular piece. So then pulling that out further, again, this metric of for specialty palliative care availability, this really highlights, again, why we didn't want to base the whole grade on this metric in particular, because as it turns out, 86.5% of hospitals with 50 or more beds in North Carolina offer palliative care. That's a lot of hospitals. That means that probably the vast majority of patients who are entering a hospital are receiving care in an institution that offers palliative care or says that they have a palliative care program. But because those scores are so high, that still puts North Carolina in the second quartile. And so that might be a place to try and look and see where else palliative care can be incorporated. But I think that's still a good score. And so that's just something to take into consideration as you're looking at the whole grade, or the whole star rating. North Carolina does actually do quite well on the count of state certified hospice and palliative care professionals per 100,000 members of the population. And so we pulled these numbers looking at the certified doctors, certified nurses, certified social workers, one other. So that takes into account all of the certified professionals that we could find. When it comes to the second domain for payment for palliative care services, we have not yet seen any state legislation or regulatory activity to expand palliative care payment. And then we looked in each state, what is the largest commercial payer in each state? And then do they have a unique benefit for enrollees with serious illness? And so the payer that we identified was Blue Cross Blue Shield, and they did not appear to have a unique benefit. We already talked about structured champions, so I think we can save that for later. But again, so there isn't that legislatively established council, but there is your coalition, and we know how important coalitions like yours are. And so that is new in this. That's something that we felt very passionate about. How is it that we can factor something into the methodology to highlight the important work being done here? Looking at building specialty skills outside of specialty palliative care. So for relevant medical or nursing continuation requirements, we were looking at basically, actually I can go into this later, but some states do have directives, topic-specific requirements on palliative care specifically, but then also looking at, is there continuing education requirements on Alzheimer's, geriatrics, end of life, or pain management? We did not specifically include opioid prescribing as a response to the pandemic or opioid epidemic, just because that's a little different. But that might be an opportunity to embed that into capacity building. And then for the count of clinicians who completed at least one CAPC course per 10,000 in the state, we found that it's 155.2 clinicians. And so that puts North Carolina in the second quartile. And then looking at the Foundation for Functional and Caregiver Support. So we did find a Medicaid waiver that provides extra services for children living with serious illness. And so that was full marks. And then in the AARP scorecard, North Carolina's ranking was 41. And so that put the state in the bottom quartile there. So taking all of that together, that gave the state 4.25 out of 10. And so then to adjust that out of 5 stars, we divided that in 2, but then we rounded up to normalize that. So this actually puts North Carolina in fairly good company, that we see a good number of states that have received 2.5 stars. And I think what I want to highlight here is that, again, part of looking or considering this methodology is really wanting to consider or give states credit for where they have invested and put time. A star is not easy to earn the way that we've calculated this. And so there is something to celebrate that, North Carolina does perform better than a lot of other states. And there are still opportunities to build. So this is also, where does North Carolina fall within its region? So in the South Atlantic region, that includes, this is probably the biggest one, Delaware, DC, Florida, Georgia, Maryland, North Carolina, South Carolina, Virginia, and West Virginia. And so this is how North Carolina compares to those states. So now what? Suggestions to strengthen capacity. I hope many of you have seen, but here's the link, is that beyond the national roll-up scorecard, CAPC also developed individual state reports for every state. I have to say, we are one organization, and so we were looking at a very high level. So this was our effort to populate everything that we know or we could find about your state into this piece, but you know more than we do. And so if there's anything that we're missing or anything that, please do let us know. And this is something that we can factor in. But the goal here was to just give you a cheat sheet of everything that we could find. So what are the existing palliative care structures? Where does hospital palliative care exist? What do we know about the certified clinicians in your state, about continuing education requirements, the number of organizations that are already CAPC members, the payment landscape, et cetera. And so I encourage you to take a look at this because it gives a lot more detail on what we know about your state. So this is just a starting list. We have on every state report and in the scorecard itself, we have a list of recommendations, and these are meant to be across all 50 states. And so we want to highlight that not every state or every recommendation is going to be appropriate for every state, nor do we think that you should pursue everyone because we know that resources are limited. And a lot of this comes down to feasibility, which we talked about. It sounds like you've already had conversations with the legislature in North Carolina about, is there an appetite for councils? So that's something to consider. And what's going to be impactful. And so this is more to get you thinking about what might be good options. And so based on the scorecard, these are some of the things that stood out to me. Obviously, we talked about the council. Um, there are several states that are looking for or working on that specialty, that benefit, Medicaid benefit for community-based palliative care. That might not be where North Carolina is right now, just based on the score, but there may be a way to embed palliative care into existing Medicaid offerings. Although I will also caveat that we know that this is a challenging and going to be an increasingly challenging time for Medicaid programs. So again, more just food for thought. And then the idea of potentially looking at continuing education requirements for your doctors and your nurses and even your social workers, if there may be an opportunity to introduce palliative care specific or relevant topics in there. Something else to flag is that CAPC maintains a provider directory, and that's on getpalliativecare.org. And this is important for a couple of reasons. First and foremost, because if there are patients in North Carolina that are looking for where palliative care exists, they can go to GPC, they can type in their zip code or their state, and whether they're looking for hospital, nursing home, office or clinic-based or home-based programs, and then that can populate a list of where we know this to exist. We had tried initially to incorporate a measure or a metric on community-based palliative care in the scorecard itself, but unfortunately we just didn't have enough participation in the registry nationally to feel confident that we're going to be able to adjudicate states or rank states against each other based on that. So that might be something that we look at in the future, but for now, the most important thing is to be able to make sure that patients and families know where to find palliative care. So I will say that I was actually surprised because North Carolina appears to have blown it out of the water with the number of programs that are listed in GPC. Usually I'm doing a pitch on these presentations when there's only one or two red dots on the map. That doesn't seem to be the case here. So congratulations to you on that. And still worth taking a look. If you have a program, it's not reflected on the map, please do make sure or visit this URL and make sure that you're listed. So finally, just looking across all of the states for states that fared well versus states that have other opportunities, what were some of the success factors? I think a big thing is meaningful coordination across all interested parties. And again, that's why we highlight those structures for advocacy and champions, because it is those bodies that are making sure that all the different stakeholders that are involved are rowing in the same direction. We talked about prioritization. Obviously, you can't boil the ocean. A lot of palliative care champions, there's just not many resources. And so again, looking at where is the appetite to do work? What is going to be feasible? What is going to be the most impactful? And then coordinating the efforts there. And so, and then also understanding the current resources. And so Obviously, there are surveys, and Marisette and I actually worked on a project recently where we have come up with a template um, borrowed from the National Palliative Care Registry, the Palliative Care uh, Collaborative, and then surveys that other states have sent out to come up with a template that if you want to try to do an effort to understand your local landscape, you could borrow this template, you could then send it out so you don't have to create a survey from scratch. And CAPC and the National Academy for State Health Policy have a lot of useful resources, so I encourage you to check them out. Um, CAPC maintains something called the State Palliative Care Forum. It is free, it is open, it is basically where whenever I've met people who said, we'd love to know what other states are doing to advance palliative care, this is a space where people can share what they're working on, ask questions. I try to pop in events that are coming up. And so then the charge to this coalition is also to get the word out. You know, our goal is really for the scorecard and the individual state report to be a tool for you to support your decision making, to support your advocacy. And so we do have a social media kit that has sample posts, a sample newsletter article, little snippets of your state that you can drop in. And so just to help you get the word out. And then finally, if you are interested in learning even more on the scorecard and our methodology, we did a webinar in December that looks a lot more into the numbers and our approach to developing the national scorecard. And that is available on demand on capc.org. So with that, I will stop sharing my screen and we can chat.
That was wonderful. And I'm sure I'm not the only one that has questions and observations while you all are pulling together questions, ideas, thoughts. My wisecracker comment is that I don't care for the fact that Duke blue was considered a better color on your heat map than Carolina blue. So I noticed that, it is March Madness. And so just wanted to add that I know you were trying to do colors that were probably meaningless. Those are very meaningful in North Carolina, so whatever. That's
Okay, so I'll bracket to say that how we color the map was like a whole thing. So we have this version of the map, which is a heat map, but at the Academy, the recent annual assembly with the Annual Academy for Hospice and AHPM and HPNA, at the plenary, we also developed a different colored map. I can share that with this coalition. Happy to support your use.
and then I realized the background that I have is sort of it's a mix of blues, so it doesn't go with anyone. But yeah, that's my first. My other interesting, my irreverent, I don't know, comment. While we're geeking out on scorecards, I think it was ARP's LTSS scorecard, which I used to do a lot with, but I haven't. I think that was the scorecard that North Carolina was also annoyed that something was counted differently. And so we had a score. I was at the national meeting, the caregiving thing, and it may have been that or another one. But I do think that is an interesting thing because you used the LTSS ARP's scorecard in that, which meant if there's a, yeah.
If
If
there's something
anyone
to
wants to
flag in one, yeah.
geek out on methodology, but I know I was at a meeting with someone and they're like, we're not, we are doing something, but it wasn't reflected in the scorecard. It was really funny. I had one comment and then just to kind of warm up for other people. I did see this and take a look at this when I was working with some of the others as we were doing our legislative policy priorities, and we're going to be talking about that a little bit later in the meeting. And we did talk about Medicaid coverage, comprehensive Medicaid coverage for palliative care. Under that um, item, as I have been taught by some of you on this call, we do have Medicaid coverage for palliative care, but it is limited in that it covers physician, you can bill for doctors and nurse practitioners, but it's not comprehensive in that it bills for the full interdisciplinary team's actions. So I don't know how that plays into the scorecard or where we were with it, but like we have Medicaid funding for palliative care. It's just not as comprehensive. And so we literally worked on that language about a month ago.
Yeah, no, that's a great point. And actually the distinction is that I would venture to say most, if not all, we say like palliative care is paid for in certain ways. So in Medicare, but also in Medicaid, physicians and then also, like you mentioned, advanced practice providers can bill for individual components of the patient encounter in the way that they would bill for any normal service. And so we see physicians billing E&M codes for the time that they will spend on their palliative or on palliative care with their patients. What then we were looking at is, again, that going beyond piece, which is that is there a payment or a bundle of payments to support the full interdisciplinary team, also looking outside of the acute care setting. And so that's kind of the newer frontier. And so, at this point, very few states got credit for it because very few states have that. Right now, it's California, which issued a directive to its Medicaid managed care plans that they needed to cover interdisciplinary palliative care. And that law was passed in 2014 and then went into effect in 2018. So a 4-year incubation period, which is also something to consider. And then Hawaii was the first state to get an approved state plan amendment from CMS to create a new payment for a palliative care benefit. So then we've seen other states that are working on this, Washington, Maryland, New Jersey, a handful of other states that have these work group processes that are in the process of developing the parameters for a benefit, but it's really just right now only California and Hawaii that have it. So
Thank you. That's helpful for our clarifications and our advocacy efforts. All right, group, other questions or reactions when you see how North Carolina fared? We did already talk about the advocacy
yeah.
advisory council.
And actually, if I may, I wanted to say one more thing because I meant to say it in the presentation, is that as you're looking ahead and using this data, there are going to be recommendations that could improve your score on CAPC's scorecard. And then there are going to be recommendations that might be the right thing to advance care for patients. And so to the extent that this is, I think, the scorecard recommendations, I think those are in service of improving care for patients, but may or may not be the right thing for you to do. And so I think we recognize that there's a distinction that there was another state presentation that I gave where they said, listen, like we just don't think that adding continuing education requirements is going to be
Mhm.
revolutionary here. So it would improve our score on the scorecard, but that's maybe not where we want to spend our time. There are other states where that might be the only feasible thing that they could do. And so if that's the only feasible action, that will have a benefit if there's a way to improve palliative care understanding. And so I want to highlight that we are not necessarily in a camp of that North Carolina should do something to raise its stars. This is really intended to be of service to you, and that hopefully, or I know that this group is so passionate and educated, you can make the right decisions based on what you know about your state.
I love that. The focus on the big picture of
Yeah.
why it's really necessary and what makes sense. Other questions, observations? I know it was a lot to take in.
Okay.
I had one other one.
Of course.
Oh, silence. And I was taking notes. One of the things, because I come from the aging space, and I remember a conversation years ago about when do you have specialty work like in geriatrics, and when do you infuse it into the general practice? And
Mhm.
I had flashbacks of that during your presentation. Are there issues that are we trying to increase the patients, as Ellie was talking about before, the patient-centered experience and the goals of care conversations, and what needs to be within the palliative care specialty versus when do we want to infuse this across all healthcare? And I just wondered, because I'm not in the palliative care space as a provider, if those same discussions are going on. When are now generalist things that you want to have versus what still remains in the palliative care box?
Yeah, no, I think that's a great question and an important one. From where CAPC sits, we believe that every clinician in the healthcare system should know how to have a conversation with their patients. They should be able to do basic pain and symptom management within their scope, and getting the training to increase their capacity to do that. They should be able to recognize the needs of caregivers and be able to provide some basic support, and then know when to refer to specialty palliative care. And that's really important because every clinician is going to encounter somebody living with serious illness in their practice. And so having that capacity to do some of those core services just to provide better care is really, we think, the work of everyone. We would then say things rise to the need of specialty palliative care if there are particularly intractable symptoms, really complex needs, multimorbidity, where it's really hard to get a handle on the symptom needs of the patient. If there are really complex family dynamics, we know that some families are more challenging than others and really need that extra training in navigating care coordination and family complexity. Those would be times where it would be beneficial to bring in that specialty palliative care team. It's a little bit more of an art than a science. And because we also are coming up against historic workforce shortages, I don't think we have a perfect answer. But again, we would want to see every clinician be able to do the basics. And then if there's a really, really complicated case, that would be then the time to bring in specialty palliative care.
Mhm. I know I'm talking a lot, but for those of you who have not experienced months long stays in the ICU, like as many of you know, I did with my father, one of the things they don't teach you about being a patient or a caregiver or family advocate is that there's rotations. And so every week, the ICU docs change. So, and I remember saying, who's God here? Like, so you put all of your care and the attending physicians and the ICU and all the other folks. And then at the end of a 12-hour shift, but also at the end of the week, you have a whole other person for the next week. And there's not continuity if you have the joy opportunity of staying for more than a week in the ICU. And so what was great is when we got palliative care in, and I had to ask for it and said, do we need palliative care? And they said, yes. And they said the benefit will be it is your only consistent provider. The palliative care nurse and social worker were the only consistent faces we saw throughout. Now, we were there long enough by being there, I don't know, 4 months, that ICU attending docs would come back on rotation like a month later. But I think that's also another really beautiful thing. So I know that I asked about a generalist, but I also want to do a shout out. And I don't think a lot of people realize that in certain situations, your only consistent voices in really intense situations is going to be your palliative care team. So wanted to give a little from the field.
Thank you for sharing that. Yeah.
Mhm. Any other comments, questions, Yocasta?
Hi, thank you, Heather, and hi, Stacie. Thank you for being here. I had a question, and you sort of touched on a little bit on that. Coming from the caregiving space, in terms of palliative care at home, what I hear, the reports I hear from other caregivers, is the lack of training. And you were talking a little bit, so I was wondering like how much effort there is into that to support caregivers at home. What I hear the most is I wish I would have kept them in the hospital. I forget about the fatigue and the exhaustion and the stress, but yes, they actually reporting that they weren't equipped, that they wish they would somebody would tell them what to do, like exactly what they needed to do. And it's a lot on caregivers because they deal enough with the, grieving and the loss. But also, feeling like guilty. Maybe I did something wrong. So anyway, you get the idea. So,
Absolutely.
yeah.
Yeah, and I wish I had a better answer for you. I think what I can say is that we've seen a lot of data out there about, patient preferences, the desire that the vast majority would like to be at home, receive their care at home, die at home. What we think may get lost in that conversation is the understanding of what it actually means to be at home. That might be where the patient feels most comfortable. And certainly the hospital or these acute facilities can be uncomfortable. But what does that mean in terms of what is then being asked of the caregiver?
I know those of us who are family caregivers are like, no.
Right. So what is being asked in terms of time, in terms of labor, in terms of resources, in terms of durable medical equipment in the home, and that there's an element of that's not what many patients want to do to their loved ones. And so even if the idea or the theory of being at home sounds great, then I think even quite a few patients, once they see the toll that that's taking on their loved ones, may have made a different choice. And so I think when sometimes palliative care can come in and support informed decision making. It's not about telling you what to do, but really taking the time to educate you on the implications of your decisions. So if you're going to receive this therapy, this is what this actually looks like. This is what you may be able to do and not do. If you move into the home, this is going to be what's available to you. So it doesn't necessarily mean that you will get the services that you need in the home, because we do need to work on that in our country, but at least there's more informed decision making. And then also, because there is a growing awareness of the importance of caregivers, we are seeing more recognition of that. There are new codes that the Centers for Medicare and Medicaid Services are paying for to at least help physicians train caregivers on some of the practical aspects of care. So it's slowly moving in the right direction, but yeah, there's a lot more work to be done.
Thank you.
Heather, did you have a comment? I wasn't sure.
No, actually, Stacie read my mind, because I was thinking about, the caregiver codes and how that does draw attention for, medical services to know, hey, we can do this work and we can be, not that it's the most important thing we do, but be compensated for the time that we're going to build out for what's really important when it comes to caregiver training. So yeah, she read my mind. Nothing else to say other than to co-sign, and thanks for mentioning that.
Excellent. Well, thank you so much. I know I'm both moving forward and then all this sort of nostalgia of going through, my own experiences. And as many of a number of my dad did a miraculous recovery. He's great now. And somehow even then, but the palliative care people talk me through what are the comfortable ways to die? Here are the different trajectories of how we could die. And they were like, that's not a bad way, or here are the decisions. And so they were so great. And then that bionic man is doing great and is in meetings right now and is off on a business trip tomorrow, and he's 87. So that story has a happy ending for now, but I now want to keep all my palliative care friends on speed dial for the next crisis. Stacie, thank you so much. This was really helpful, I think, and just wonderful to have you and Heather together to really motivate us as we think about next steps. And we're about to talk about some of our advocacy and some of our other efforts, but this is really in alignment with where a lot of us are thinking through, even about how we don't separate out issues of serious illness conversations. Don't separate out issues about what's happening with caregiver support. Don't separate, like, where's the through line in all of this? And it does come back to what you said, Stacie, the big picture is on, how do we support patients and families? Like, what's the big picture we're trying to, and it is kind of fun, both seriously and jokingly, to talk about scorecards and things like that. But really, at the end of the day, it's what are we all receiving for ourselves and our people. So,
Well, thank you so much for having me. You now have my information, so please do reach out if I can support you. CAPC can support you in any way. And thank you all for the work that you're doing, because it's really essential.